Okay. So once you have considered giving fluids in patients with any kind of shock, specifically septic shock. So let me discuss something about septic shock again. Okay. How do you diagnose sepsis? Now, I promised that we'd discuss something about the new sepsis. So what we discussed was early goal-directed therapy, which was recommended and parts of which are followed now, not totally, but parts of which are followed now. So what is new about sepsis? So the definition itself has changed. I'll talk about old here once again. Old. Sepsis was SIRS plus suspected or proven infection. This was diagnosed as sepsis. There's something called severe sepsis, which included sepsis plus one or more organ dysfunction, or sepsis plus lactate more than 4, or sepsis plus hypotension responsive to fluids, right? And septic shock. The classic definition of septic shock was sepsis plus hypotension not responding to fluids or needing vasopressors for maintaining the map, maintaining blood pressures. So the need for vasopressors used to define septic shock in previous definition. Okay. Now sepsis is defined by something which is called as Q-SOFA score. Okay, so this is quick. Q stands for quick, sequential organ failure assessment. Okay, so this is a Q-SOFA score. Why is it important? Because this is new, just recently changed. There may be questions asked on the definition of sepsis. So you guys need to understand what this is. So by definition, sepsis is a SOFA score, a change in SOFA score by more than equal to 2. Okay, in a patient with suspected infection, plus change in SOFA score from baseline by more than equal to 2. But this SOFA score involves a lot of systems and is a complex tool. It's not very handy when used in the emergency department, when you don't have a lot of time and a lot of things to be done to the patient, and so easier tools would be required and not something which is as complex as a SOFA score. A quick screening tool, therefore, is used, which is called Q-SOFA score. It's a very easy score to remember by rule of 2. And ABCs again, always ABCs. Emergency medicine is all about basics of ABCs. Okay, so but here the ABCs stand differently. A is not for airway here. A is for altered sensorium, which actually is D classically. But to remember this score, altered sensorium, respiratory rate of more than 22, and blood pressure systolic less than 100. So how do we remember in the form of rule of 2? If the quick SOFA is more than equal to 2, that's first sec 2. Altered sensorium, respiratory rate is 2 and 2, and SBP in 2 digits. Okay, so this is rule of 2. So if any two of these three is present, you would say that Q SOFA is positive. Ideally, then you go now, if this is positive, then you go for calculation of complete SOFA score to then diagnose sepsis. Now, as per the new definitions, new guidelines, no severe sepsis. This term has been removed. The septic shock now has been changed, and it says patient with sepsis, that is there, sepsis plus, if there is a lactate of more than 2 or hypotension, either of them after adequate fluid resuscitation. If any of them is present this way, then this is considered septic shock. Okay. Again, septic shock as per this definition also requires vasopressors. So this is the new definition of sepsis. Quick SOFA score to diagnose for septic, definition for lactate and fluid resuscitation. Right? Having talked about defining sepsis, the use of vasopressors is paramount. So much so that early use of vasopressors has been suggested to improve the patient's mortality. So now, let me discuss something about the vasoactive agents to increase the blood pressures and all. Okay, so the vasoactive agents could be vasopressors, pure vasopressors I would say, inopressors, inodilators, or vasodilators. Okay, what does all this mean? Okay, so vasopressure, what do you mean by vasopression? By vasopressure you mean increasing the systemic vascular resistance by arteriolar constriction, arteriolar and venous constriction. You increase the systemic vascular resistance. Inotropy means increased cardiac contractility. Chronotropy means increase heart rate. But for us important is inotropy and vasopression. Pure vasopressors include phenylephrine, pure alpha agonist, which causes pure vasopressor, and some aspect of reflex negative inotropy. Okay, inopressors are the ones which cause inotropy, which have both inotropy and pressor effect. These include norepinephrine, epinephrine, dopamine. Inodilators cause inopressure, they have an inotropic effect but cause vasodilatation, usually because of reflex. Okay, typical example are milrinone and dobutamine. It's important. So now, depending on the patient's situation, whether he requires a lot of vasopressure effect or causes an inotropic effect, depending on the condition of the heart, the agents are chosen. In general, the drug of choice, the vasopressor of choice in sepsis, or I would say rather septic shock, septic or septic shock, is norepinephrine. It takes care of the vasopressor effect, it takes care of the inotropic effect. Both of them are taken, and it has low side effect profile. It is much better than dopamine, which is considered to be a bad vasopressor. and is almost out. Almost out. Okay. If this does not take care, okay, another important is vasopressin. Obviously, this is a vasopressor. If this does not take care, then we use vasopressin. This has catecholamine sparing effect. Or we could use epinephrine now, right, which has higher inotropic effect. If at all we need, if like last resort, we have dopamine. We don't use dopamine upfront. This is bad medicine and is reserved for the last step. Okay? If we need, in sepsis, if we need inotropy more, then the inotrope of choice is dobutamine. This is not a vasopressor. This would rather cause vasodilatation. Okay? So the dobutamine is not a vasopressor. Rather, it can, I would not say always, it can cause hypotension in 1/3 of the patients. So it's not used primarily to increase the blood pressure, but it is used for augmenting the cardiac output. Okay, so this is about the physiology of using pressors. Okay, so the correct choice of vasopressors, wherever there is dobutamine, strike it off, because dobutamine is not a vasopressor. Okay, rest of the option, as I said, norepinephrine is the drug of choice. Okay, so this goes out, vasopressin is not. Dopamine, as I said, it would be used last. Okay, dopamine should not be here, so this is out. The answer is C. Norepinephrine, epinephrine, dopamine. Had there been a vasopressin here, that would also have been correct. Okay, so vasopressin, epinephrine are second choices, second and third choices. Okay, norepinephrine followed by epinephrine and dopamine. Right. Okay, we come to the next one. What is the correct route and dose of epinephrine in anaphylaxis? So when we talk about epinephrine in septic shock, this is IV, this is not IM. As we considered in anaphylaxis, no, this is an IV drug. Okay, so this has to be used intravenous infusion. All these vasopressors are used as intravenous infusion and titration to effect. Okay, but the route for anaphylaxis is, first of all, it should be IM. Okay, so we have IM, it's not IV. Anterolateral thigh. Okay, not gluteal area. And the dose is 0.5 ml, not 1 ml, 0.3 to 0.5. Okay, so the correct answer is 0.5 ml, 1:1000 intramuscular anterolateral thigh. All the four components are important. Okay, so the next couple of questions will be based on the concept which is very important, that is the management of patients with dengue. So currently, as I speak, this is the season when the dengue is quite prevalent, and there are a lot of deaths as well because of a severe dengue infection, especially in and around Delhi and in other parts of the country as well. So let us see and understand some concepts about management of dengue first, and then maybe we can go to the question and discuss a lot of answers there as well. Okay, so first of all, if we talk about dengue, it has 3 phases: febrile, critical, convalescent phase, or resolution. Okay, so typically dengue starts as an acute febrile illness, which could be anything like malaria, Undifferentiated febrile illness like malaria, leptospira, scrub typhus, viral prodrome, and acute HIV syndrome, or anything else as well, right? So this is an undifferentiated febrile phase, which in most cases progresses to resolution in some time after a few days time. However, in some patients this goes on to develop into the critical phase, in many cases this goes on to develop into a severe illness, and this happens mostly during the critical phase, and this critical phase lasts for around 48 to 72 hours. This is the window in which most of the complications happen. This starts usually on day 3 and persists till day 5 to day 7 of fever onset. Okay, so fortunately dengue is not a condition which directly goes into severe illness. Most of the time it gives us an opportunity to recognize and foretell whether the patient will go into severe illness if not treated, is the presence of warning signs. If the patient has any one or more of the warning signs, this is an opportunity to prevent the disease going into a severe dengue, severe illness. If there are no warning signs and the critical period has been passed, the patient enters into convalescent phase. Or if there are warning signs and the patient has been managed properly, it bypasses the severe illness and goes into convalescent phase. And even if the patient is in severe illness, if managed properly and it surpasses this time period of 48 to 72 hours, then it goes into convalescent phase. Okay, so this is about the progression of dengue. So let us see what these warning signs, these important warning signs are. These include recurrent vomiting, severe abdominal pain or tenderness, drowsiness or agitation, that is any alteration in mental status, presence of a mucosal bleed like epistaxis or gum bleed or petechia for that matter, right? Presence of clinical fluid accumulation in the form of pleural fluid, ascites, etc. Right? Next warning sign is presence of hepatomegaly more than 2 cm and thrombocytopenia and rising hematocrit. There is a combination of these two. Okay, so these are the 7 warning signs: recurrent vomiting, severe abdominal pain or tenderness, hepatomegaly more than 2 cm, presence of drowsiness or agitation, mucosal bleeding, presence of clinical fluid accumulation, hepatomegaly, which I've covered, and thrombocytopenia with increased hematocrit. If there is any one or more of these warning signs, one should consider a possibility of landing up into severe dengue. Now, which comes to the definition of severe dengue. If dengue fever is associated with shock, organ dysfunction, shock or organ dysfunction, or significant bleeding, more than the mucosal bleeding which we have mentioned, or clinically symptomatic fluid accumulation, like ascites or pleural fluid causing respiratory distress. So if any one of them is present, this is considered to be severe dengue, right? Now, coming to the diagnosis of dengue, if it is within 5 days of illness, it is diagnosed, there is a presence of viremia, which can be diagnosed with NS1 antigen card test. If it is beyond 5 days of onset, it is diagnosed using IgM dengue. Again, because there is no viremia by this time. Okay, so this is how you diagnose and confirm dengue. Some of the pointers towards the possible dengue in febrile phase. Okay. Yeah. So some of the pointers towards diagnosis of dengue during the febrile phase include positive tourniquet test or presence of leukopenia. If any of them is present, there is a possibility of dengue, which is increased in such patients. Okay. So, just to recapitulate till now, there is a progression from febrile to critical to a convalescent phase in dengue, right? Febrile phase to critical phase to convalescent phase. There could be a simple febrile illness which then goes into resolution, or there could be a febrile illness which through warning signs progresses to severe illness and then goes into convalescence, which is called severe dengue. Okay, we've discussed about the warning signs of dengue, which include recurrent vomiting, severe abdominal pain or tenderness, drowsiness or agitation, mucosal bleeding, mucosal skin bleeding, presence of clinical fluid accumulation, and presence of hepatomegaly more than 2 millimeter, and combination of thrombocytopenia with a high hematocrit. Okay, so these are the warning signs. And when do we call severe dengue? Is presence of dengue with shock, organ dysfunction, significant bleeding, or clinically symptomatic fluid accumulation like either ascites or pleural fluid causing respiratory distress, right? So we have also talked about how to diagnose dengue. That is, diagnosis is confirmed if it is within 5 days of illness. It is confirmed by presence of NS1 antigen card test, and if it is beyond 5 days, it is diagnosed with IgM dengue immunoassays. Okay, so this is how we how we look at dengue as a progression. Now let us discuss as to how to manage dengue. So it's a complex and a severe disease. It's a potentially severe disease, but the treatment is very, very straightforward, and the treatment is fluids. As simple as that. Treatment is fluids. We need to know monitoring. We need to know how to monitor these patients and what to avoid. These are the 3 pillars of management of dengue. Now, depending on the phase, let's see how the treatment varies depending on the phase. So for the febrile phase, if it is just the febrile phase and it is before the patient who has come to the critical phase, get the CBC, which will give you the baseline. Okay, get a CBC, give antipyretic, which is paracetamol. Right? No other drug. You can do tepid sponging and watch for warning signs. This is important. right? So this is the only treatment. I need to avoid a bunch of things. Let's see what we need to avoid. We need to avoid a couple of things. NSAIDs, steroids, IM injections, antibiotics. There is no role of antibiotics upfront within 3 days of illness. Okay, IM injections and prevent trauma. You cannot avoid completely, but obviously like that there could be accidents, but you need to take care that the trauma is reduced to minimum, or if you can avoid sustaining any trauma, because these patients have, if any of these conditions is there, there's an increased risk of bleeding. So these are bad. So this is the treatment in the febrile phase, as simple as tepid sponging and paracetamol. However, if the patient develops warning signs, this becomes an indication for intravenous fluids, and this prevents severe dengue. As simple an intervention like IV fluids prevents severe dengue, right? So if the patient has warning signs, start off with IV fluids. You start at around 4 to 6 ml per kg per hour for 1 to 2 hours, and then reassess. In the part of reassessment, we have two things. One is clinical condition, and second is repeat CBC. If the patient is clinically better, then taper fluids. If it was started at 6, bring it down to 4, to 2, to 1, and then stop. With monitoring, obviously. If the patient is not clinically better, look at the hematocrit now. Okay, if the hematocrit is rising, there is hemoconcentration. You need to increase the fluids. If the hematocrit is falling, there is a possibility of hemorrhage. Common sites of hemorrhage include GI bleed or massive menstrual bleeding, or it could be occult as well. So you need to consider colloids here, and eventually blood products, which include fresh whole blood, not fresh frozen plasma, mind you. It's fresh whole blood or packed RBCs, right? So this is an important concept to understand. We'll just recapitulate it once again. Okay, so the patient has any possibility warning signs or severe dengue, then go ahead and give IV fluids. The rate of IV fluids depend on what state the patient is in. If the patient just has warning signs, you start at a different rate. If the patient is in shock, you give initial resuscitation and then go at a infusion rate, right? So that depends. So you start off with fluids, and the reassessment is done for all the patients, and clinical assessment is done, and CBC is repeated for hematocrit. If the patient is clinically better, you taper off fluids. If the patient is not clinically better, or the patient worsens clinically, then important deciding factor would be a change in the hematocrit. You look at the hematocrit, if the hematocrit is rising, there is hemoconcentration, and therefore the fluid infusion should be increased. And if the hematocrit has dropped down, that suggests presence of an ongoing hemorrhage. So look for the source and start off with whole fresh blood or with PRBCs. So this is how you overall go ahead and manage a patient with dengue. So now let's come back to the question and see how we can answer them. Okay. Yep. So this is a 20-year-old female who presents with 4 days history of fever, with chills, body ache, 4 episodes of vomiting, and severe upper abdominal pain. So this patient is in critical phase. That is one. Right? The patient has severe abdominal pain and vomiting. So she has risk factors, that is warning signs. But wait, she has a pulse rate of 120 and a blood pressure of 80. So the patient is already in shock. So this is a decompensated shock state. For the patients with decompensated shock, you need to give resuscitation fluids upfront, remember. Okay, so the dose would be around 20 ml per kg bolus as soon as possible, that is 15 to 20 minutes, and then followed by an infusion rate. Okay, if it is a compensated shock, which means the patient is hypoperfusing, but there is no hypotension as such. You remember we talked about the cryptic shock or the occult shock? This is that kind of a condition there. Okay, in that case, you need to consider a smaller fluid bolus or a higher rate of infusion, like 10 ml per kg per hour. Okay, but this patient has a frank shock, so you need to give fluid bolus. So yes, the patient was resuscitated with 2 liters of normal saline. I'm sorry, this should be her, and her blood pressure is now 100/70, which is okay. NS1 turned out to be positive, which is meaning that this is a dengue, severe dengue feature, patient with severe dengue. Now the results of the CBC which was drawn initially were out, which suggests a hemoglobin of 17, hematocrit of 54, platelets of 10,000, and a leukopenia which is 2,500 of WBCs. Now you gave the resuscitation and now you repeated the CBC of this patient after resuscitation. Right? Now we consider the following scenarios and we see how we would have responded to the scenarios with different scenarios. Okay? So, you know the initial, I'll write it down for you. The initial hematocrit values and CBC values. Hemoglobin was 17. Right? Just a second. Hematocrit was 54. Platelet was 10,000. I guess that's all what we need right now. Okay, now the patient has a blood pressure of 110/70, pulse of 80 per minute, which is better. Now so the patient has improved clinically. Okay. Hemoglobin is 16, hematocrit is 45, so hematocrit has come down. The platelets are 12,000. What is your inference? So if you remember, as per our discussion here, if the patient is clinically better, you taper off the fluids. Okay. So here, yes, the patient is clinically better, and this is suggested by the hematocrit, which has dropped down. So initially there was hemoconcentration as per the pathophysiology of dengue, but that has now come down. Is the patient actively bleeding? No. The patient is high risk for intracranial bleed and needs surgical evaluation? Not yet. This thrombocytopenia is because of the dengue pathophysiology, and that has slightly improved. Though this is significant thrombocytopenia, an upfront surgical evaluation would not be warranted in the emergency department. The patient is clinically better and needs monitoring and fluids. Yes, this is the correct answer. Does the patient need urgent platelet transfusion? No, not upfront. Unless the patient is bleeding actively, which is not responsive to the whole blood transfusion, platelet transfusions are generally not recommended in patients with, the patients with severe dengue with thrombocytopenia. Yeah? Okay. There is another scenario. Considering this as the initial one, the scenario number 2. She develops restlessness and has a pulse rate of 110 with a BP of 70 systolic. Okay, so the patient has again gone into shock. There was an initial resuscitation which was done, but the patient went into shock again. Now this time, hemoglobin is 15, hematocrit is 40. Okay, initial hematocrit was 54. What is your inference or next plan of action? Okay, yeah. So, as you can recall, if the patient worsens clinically and the hematocrit drops, you need to consider hemorrhage as one of the possibility, right? And the next step would be to give blood products. Let's see. If we have, if you can point out the right answer here. Okay. The patient is actively bleeding. Yes. The patient is a high risk of cardiogenic shock and needs steroids. No, no, no. Steroids are contraindicated in dengue. Should be avoided. Patient is clinically better and needs monitoring. No, the patient is not clinically better. The patient has developed hypotension, which is not better. So this is wrong. Patient needs urgent FFP transfusion. No, FFP is not indicated in patients with dengue, even if they are bleeding up front. So this is fresh whole blood which would be required. So this is not the right answer. Yes, the right answer would be the patient is actively bleeding. That's correct. Okay. Now the third scenario, keeping the baseline into your consideration, taking the baseline into consideration, she develops restlessness and a pulse rate of 110 and systolic blood pressure of 70. Again, the patient has dipped. Patient has developed worsening symptoms. But the hemoglobin is 18 and hematocrit is 65. What was the baseline hematocrit? 54. Now it is 65, so that has increased. What is the inference and next steps? So, as you can recall, again going back to the algorithm, if the patient worsens clinically and the hematocrit increases, there is hemoconcentration and fluids need to be given for this. Okay? Let's see. Now, is the patient actively bleeding? No. Does the patient need resuscitation volumes of fluid? Yes, because the patient is in shock. Yeah, hypovolemic shock. So, the resuscitation volume fluids will be required. Is the patient clinically better and needs monitoring? No. Definitely needs monitoring, but he's not clinically better. The patient needs N by 2 in 5% dextrose. Okay, so this is one of the preparations which is used, especially in pediatrics, as one of the maintenance fluids or replacement fluids in many conditions. But this is not what is required for resuscitation. Remember, for resuscitation it is crystalloids. And followed by colloids if needed in dengue. Okay? So the right answer would be resuscitation. Which of the following does not increase the risk of bleeding? NSAIDs increases, steroids do increase, intramuscular do. So all of the above do is the right answer. No, and it's not just a matter of fate. Okay? There are things which you can do to avoid complications in dengue, and you have to keep those in mind. Right? So this was a discussion about management and evaluation of a dengue patient who presents with an acute febrile illness. I hope you understood and you got the concept as to how to monitor and consider various treatment decision points. Okay? Okay. Now we go to the next set of questions, which comes back to the classical cardiovascular decision tree. Okay, so this is a 60-year-old diabetic and hypertensive male who presents to the emergency department with diaphoresis and shortness of breath for 8 hours duration. He has a pulse rate of 66. He is hypotensive with bilateral crepitations on the chest auscultation. Okay, so this looks like cardiogenic shock to me. There is congestion, there is hypotension, plus risk factor for an acute coronary syndrome. Okay, so this looks like an acute coronary syndrome with cardiogenic shock. Right? Now the next prudent step will be to get an ECG done. So correctly, an ECG was done and it is suggestive of an ST elevation in AVR and AVL with ST depressions in all the precordial and limb leads. Okay. So this is an interesting one. You need to understand what AVR, ST elevation and AVR means. Okay, so the AVR is the lead which is commonly overlooked, I would say, right? AVR. So ST elevation in lead AVR has important differentials. The most important of which is left main coronary artery occlusion. Well, this is a fatal condition. It causes rapid cardiogenic shock and warrants an emergency cabbage. This patient has a very high morbidity and mortality. Okay. Next is triple vessel disease. Presents similarly, but the clinical picture is not as bad as a left main coronary occlusion, acute occlusion of left main coronary artery, right? Okay. Apart from this, patients with massive pulmonary embolism can have ST elevation in AVR. Patients with supraventricular tachycardia may have rate-related ST depressions, all leads, and ST elevation in AVR. Another important differential is Brugada syndrome, which can cause sudden cardiac death in young males. It's a channelopathy. And one toxicologic differential is sodium channel blocking agents toxicity. Example include tricyclic antidepressants. Okay, this is an important thing. Till here you can see most of the conditions, cardiovascular conditions, which cause global ischemia, global cardiac ischemia, cause an ST elevation in AVR. Okay, primarily Brugada syndrome can cause it, and toxicologic causes like sodium channel blockade toxicity can also cause ST elevation in AVR. Now, there are some pointers which differentiate and which we can use to diagnose LMC occlusion. So, left main coronary artery occlusion can be diagnosed with ST elevation in AVR more than ST elevation in V1. This is one of the pointers. Next is simultaneous ST elevation in AVR and AVL. So these are 2 pointers, important pointers. After the clinical picture is clear, like the patient is in cardiogenic shock and you see this kind of a picture, then you should suspect a left main coronary artery occlusion. Okay, a close differential again would be sodium channel blockade toxicity, which could also present with hypertension, which also presents with tachycardia and ST elevation in AVR. Okay. Now let's come back to the question. So this patient has likely got an acute coronary syndrome with cardiogenic shock, and ECG has simultaneous ST elevation in AVR and AVL. So this is suggestive of left main coronary artery occlusion. Okay. A differential would be TCA poisoning, but there is no historical evidence that the patient could have possibly taken tricyclic antidepressant, or if there is a possibility of an overdose where this should be considered. Okay, which of the following is not contraindicated in this patient? We come to the options here. Mind you, so this is left main coronary artery occlusion. Aspirin, no, it's indicated, it has to be given. Morphine, NTG, furosemide. These are the drugs which decrease preload and may cause hypotension. So morphine, NTG and furosemide, they decrease the blood pressure. Okay, and they are contraindicated in patients with existing hypertension. For this, let's come back and discuss about the initial treatment of patients with an acute coronary syndrome, then the things would be much easier for you to understand. Any patient who comes with an acute coronary syndrome usually receives aspirin, clopidogrel, atorvastatin, nitrates, morphine. Okay. Okay, so not all the patients should be given. Initial, it was called O for oxygen, N, A. So initially it was said that all the patients of MI should be greeted with MONA. But this is not the case. Not all should receive all of the following, as there could be some important contraindications. Oxygen is indicated only if there is hypoxia. Right? If the saturation is less than 92%, only then is oxygen indicated. Not in all patients. Okay? Not in all patients. Morphine can cause hypertension. So it is contraindicated or avoided in patients with existing hypotension or known allergy to morphine. Right? Nitrates again can cause hypotension and should be avoided. Nitrates should be avoided in presence of hypotension, presence of a preload dependent condition. We'll discuss more about this in a subsequent question. And use of sildenafil within 1 to 2 days. Because sildenafil is a PDE phosphodiesterase inhibitor, and PD inhibitor plus nitrate can cause significant hypotension. So this must be avoided. Okay? Aspirin should be given in all patients except if there is an known aspirin allergy, and clopidogrel can be considered. All the patients should receive a statin dose upfront. Okay? So this was about the initial pharmacologic management of patients with an acute coronary syndrome upfront in the emergency department. Right? If the patient is hypotensive, nitrates, morphine should be avoided, and there is no use of giving a loop diuretic upfront. Right? So avoid morphine, nitrates, and furosemide. Aspirin is the right answer. So this is the drug which can be considered and which is not contraindicated. How about flumazenil? So this is an important, interesting thing to understand. Had someone chosen TCA poisoning as one of the answers for this question because of the presence of ST elevation in AVR, flumazenil is contraindicated in TCA poisoning. Right? Flumazenil is contraindicated in TCA poisoning as it can precipitate seizures. Hence, otherwise, flumazenil does not have any role in acute coronary syndrome and should not be considered. So there is no question of considering it to be one of the contraindications. Okay? Right. So now we know that the patient is in cardiogenic shock. Which of the following techniques may prove useful in the emergency for this patient? So for this question, you need to understand what are the full forms of these standard acronyms. RIBOA stands for resuscitative endovascular balloon occlusion of aorta. Okay? So what you do here is aorta divides into the iliac branches. You cannulate the femoral vessel, go to the aorta, and you occlude the thoracic aorta. There are various zones in which the aorta would be divided. Zone 1, 2, 3. So depending on the indication, there is a balloon which goes in from the femoral artery, backwards into the main aortic trunk and occludes the aorta. So there is resuscitative, endovascular, balloon occlusion of aorta. Okay, when is it done? This is one of the alternatives to resuscitative thoracotomy in trauma. Okay, so if there is significant abdominal bleed, instead of cross clamping the aorta, which is done after resuscitative thoracotomy, instead you do a REBOA, which is an endovascular treatment and is less invasive as compared to doing a full thoracotomy. Okay, so this is about REBOA. What does ED-ECMO stand for? ED-ECMO stands for Emergency Department Extracorporeal Membrane Oxygenation. So this is basically an artificial circulatory and ventilatory device which is used. This is indicated in patients with prolonged CPR. Prolonged CPR with a reversible cause, potentially reversible cause. In these kind of scenarios, an ED-ECMO would be a helpful thing. Okay, IABP stands for intra-aortic balloon pump counterpulsation. I'll go again. Let's see what this is about. So this is intra-aortic balloon pump counterpulsation. Okay, this is IABP. It's not the technique is not much different as compared to a REBOA. Sorry. Okay, so what is done? Again, IABP again. A guide wire is inserted into through the femoral artery into the aorta, and then a balloon is in the descending thoracic aorta. A balloon is there. A balloon is placed. So now what it does is that, first of all, it is indicated in cardiogenic shock states. What is done? That this balloon during systole it is inflated, and during diastole, cardiac diastole, this is deflated. Sorry, it's the other way around. During the systole it is deflated and diastole it is inflated. Okay, so what it does is that it facilitates the cardiac output and increase perfusion to the coronary bed with the rhythmic inflation and deflation of the balloon. It's used for cardiogenic shock, but this is not the treatment of cardiogenic shock. It is just a bridge and hemodynamic. I'd say it's a hemodynamic bridge to definitive therapy, right? So if the patient has an acute coronary syndrome, develops cardiogenic shock, needs revascularization, that is PCI or cabbage, then patient can be put temporarily on IABP to support the hemodynamics, right? So this is about IABP. What is AICD? This is automated implantable cardioverter defibrillator. It is used for the patients who are at high risk for sudden cardiac death, such as various channelopathies, various specific syndromes like Brugada syndrome. Could be used in conditions where there is decreased cardiac output because of coronary artery disease or otherwise. If the patient is in severe systolic cardiac dysfunction, he or she has a high risk for developing sudden cardiac death. In such cases, the ICD would be implanted. So the correct answer would be IABP, as the patient in consideration is in cardiogenic shock. Okay. Okay. We come to the next question now. A patient presents to the emergency department with restlessness, chest pain, shortness of breath for 6 hours. He has recently been diagnosed as pulmonary tuberculosis and not yet started on ETT. His airway is patent, but he is breathing at a rate of 28 per minute, which is tachypnea. He is tachycardic and is hypotensive. There is no pedal edema. Minimal bilateral crepitations could be appreciated on chest auscultation. ECG suggestive of tachycardia and low voltage ECG QRS complexes. Which of the following is true? Okay, so considering this situation with tachycardia, hypotension, right? This patient could very well have a cardiogenic shock with bilateral crepitation. But the point which goes against is minimal bilateral crepitations. Okay, minimal bilateral crepitation goes against the diagnosis of cardiogenic shock, that is biventricular failure. One important clue is the presence of tuberculosis and low voltage complexes. This, in presence of tachycardia and hypotension, points towards the diagnosis of cardiac tamponade. Okay. Right. So how do you define low voltage complexes in the ECG? They are usually QRS complexes less than 5 millimeter in height in all limb leads and less than 10 millimeter in chest leads. That's a gross, simple definition for low voltage complexes. There are many other definitions as well, but this is the most commonly used one in the emergency department. Okay. Let's consider the options. Bedside ultrasound is of limited value as the patient is very unstable. This is an absolutely wrong statement, because bedside ultrasound especially has a very high yield and very important diagnostic value in patients with instability. In such patients, what we do is called a resuscitative ultrasound, which helps in important decision points, right? So this statement is not correct. Immediate introduction of needle to second intercostal space may be life-saving. So this is the treatment maneuver for tension pneumothorax. You need to understand that pulmonary tuberculosis could also lead to tension pneumothorax, but this patient does not have it because there are minimal crepitations. In tension pneumothorax, you will find absent QRS. I'm sorry. In tension pneumothorax, you'll find absent breath sounds. Okay, you'll find absent breath sounds rather than minimal crepitation. So this is a treatment for tension pneumothorax and not for cardiac tamponade. So this is not right. Thrombolysis won't yield beneficial outcome. Yes, the patient does not need thrombolysis. Thrombolysis in the emergency is used typically for STEMI, pulmonary embolism, or for prosthetic heart wall thrombosis or ischemic stroke. These are the typical indications for thrombolysis in the emergency department. Thrombolysis would be contraindicated in patients with pericardial effusion, because that can lead to hemopericardium, thereby worsening the patient's tamponade. Okay? So, which of the following is true? Thrombolysis won't yield beneficial outcome. Okay? Considering the last option, diuretics should be instituted as a life-saving measure along with oxygen. Okay, so this is not correct. Let's discuss a bit about cardiac tamponade in this regard then. You'll be able to understand it much better. Okay, here we go. Right. So, cardiac tamponade. What exactly is this? So, suppose this is the cardiac sac with aorta and the vena cava, right? This is the pericardium surrounding the heart, and if you see, fluid between these two, this is pericardial fluid, pericardial effusion, which is a prerequisite for development of cardiac tamponade. Now, what are the pericardial effusions which are notorious for developing into cardiac tamponade? That can be remembered as TRIM. That is trauma, renal failure, that is uremic pericarditis, trauma and tuberculosis again, renal failure, infections, infectious pericardial effusion, and malignancy. Right? So these are the ones which are notorious to develop into cardiac tamponade, and they progress very fast. Okay, the cardiac tamponade is not related to the volume, of pericardial fluid. It is not that large volumes of pericardial fluid can only cause tamponade. It also depends, the second variable is the rate of development of fluid, rate of accumulation of fluid. Okay, so even if there is a small amount of fluid and it accumulates at a fast rate, this can lead to a cardiac tamponade. And slowly accumulating large volumes of fluid may not cause cardiac tamponade. So the exact pathophysiology of cardiac tamponade is that it causes a diastolic failure. So if there is a lot of fluid, there is an increased pressure, and it causes diastolic failure. There would be less of blood entering from the venous circulation into the ventricular cavity, and hence less of the blood will be able to go from the ventricles to the main vessels, including aorta and for that matter pulmonary artery as well. Right? So this is the main pathophysiology of cardiac tamponade. How do we diagnose it? One is a clinical diagnosis. When you talk about Beck's triad, classically described as raised JVP, hypotension, and muffled heart sounds. This triad is not common and not practically seen in a lot of patients, especially in a busy emergency department. This is a sign which is very difficult to elicit, and so is raised JVP. In addition, a raised JVP may be absent. This may be absent in patients with coexisting hypovolemia. So if the patient is hypovolemic as well, there will not be any raised JVP. Okay, so you should not rely completely on Beck's triad clinically. Any patient with hypotension and raised JVP, you should consider cardiac tamponade as one of the differential diagnosis. The diagnosis is clinched by a bedside ultrasound. Okay, so bedside ultrasound shows you fluid plus presence of pressure. That's what is the diagnostic for cardiac tamponade, right? So the fluid is seen as an anechoic shadow, as I had shown you. It's seen as an anechoic shadow between the pericardium and the contracting heart. And the signs of pressure include diastolic collapse of our right ventricle or a systolic collapse of right atrium, right? So these indicate intrapericardial pressure and a diastolic dysfunction, a diastolic failure of the heart, thereby causing obstructive shock. Now, an important adjunct to diagnosis is an ECG, which shows low voltage complexes. So mind you, these ECG signs are not the signs of cardiac tamponade. These are the signs for pericardial, significant pericardial effusion. Okay, so the low voltage complexes is one, and electrical alternance is a second ECG sign. Though these the electrical alternance is a very typical sign and is not seen in most patients with cardiac tamponade, low voltage ECGs could ECG QRS complexes could be one suggestive feature which could raise the suspicion in a patient with hypertension to consider tamponade as one of the differentials. Now, how do you treat tamponade? The definitive treatment is pericardiocentesis. There is increased fluid in the pericardium, just remove it out. Pericardiocentesis. This could be a fluoroscopic or an ultrasound guided. Fluoroscopic guided or ultrasound guided. There are the two ways of doing the pericardiocentesis. Either of them can be employed depending on the availability of resources. Now, one exception to this is trauma, because mostly cardiac tamponade results from a damage to the ventricular or atrial free wall. So if you remove more blood, more and more blood will accumulate, and this will worsen the situation. So in trauma, the pericardiocentesis is utilized only as a temporizing measure, and the definitive treatment is thoracotomy. Okay, so thoracotomy is the definitive treatment. In addition, till the time you should consider increasing the preload, so that if the patient is having an existing hypovolemia because of many reasons, there could be at least a correction of intravascular fluid that may lead to some improvement in the hemodynamic status. So you need to give fluids to such patients. However, excessive of fluids must be avoided, as they are not going to help if there is a significant increased intrapericardial pressure. Okay, so this was about cardiac tamponade. So let's see. Hence, the diuretics should not be given. Diuretic is instituted as life-saving measure. No, this is not a correct statement. So the correct statement is thrombolysis won't yield any beneficial outcomes. Right? Okay.